At the turn of the century, there were some breast-conserving procedures taking place, but axillary lymph node dissection remained the standard of care because it was thought to be a sign of systemic disease and an indication for radical surgery. However, there were some randomized studies which demonstrated comparable outcomes and lower morbidity from less extensive axillary surgery. The sentinel lymph node biopsy concept arose from the fact that in various types of surgery, of cancer surgery, it was noted that certain anatomical positions were very important for the prediction of prognosis. And Donald Morton used a lymphoscintigraphy for malignant melanoma, and he developed the concept of the sentinel node, appreciating that there was an anatomical stable route of lymphatic drainage to the regional lymph node basin. So if we think about lymphatic anatomy, it's like arterial anatomy. It has a very stable anatomical morphology, unlike the venous anatomy, which is variable, okay? And so if we can check the first lymph node on the route from the primary to the regional basin, and this is negative, it doesn't have any malignant cells, we can avoid prophylactic lymph node dissection. That concept worked for breast cancer, and the technique evolved over the years and became very well established with sensitivity of more than 95% and specificity more approaching 100%. And of course, the benefit was great because the sentinel lymph node technique had less complications than the axillary lymph node dissection. So less shoulder dysfunction, avoiding division of the intercostobrachial nerve, which leads to hypesthesia at axillary lymph node dissection, diminished post-mastectomy pain syndrome, and generally a good quality of life even in the first postoperative years. So at the present moment in time, if we consider about the axillary management for breast cancer, the surgical options are three: no surgery to the axilla, sentinel lymph node biopsy, or axillary lymph node dissection. And of course, we have many choices of systemic therapy, and we have some choices of radiotherapy, which is no radiation versus breast and chest wall radiation versus breast and chest wall plus regional lymphatic basin radiation. And the progress in all those subspecialties, especially in the field of medical oncology, drove selective surgical de-escalation, and the doctors nowadays involved with breast surgery, with breast cancer, should be aware of many observational studies, randomized control studies, systematic reviews, meta-analysis, etc., that keep on being produced at a very fast pace. And as far as guidelines are concerned, 2022 was a year of guidelines. We have the third update for breast cancer guidelines from the NCCN, the ASCO, together with the Ontario Cancer Healthcare, recently published some guidelines on breast cancer and axillary management, and the American Association of Breast Cancer Surgeons again, recently published a consensus on axillary management for patients with breast cancer, which is concise, and because this is a surgical lecture, we're going to follow that to keep things more practical. So, there is no need for axillary node staging when it will not affect adjuvant therapy planning. Because if there is advanced age or serious comorbidities, and these are not allow the administration of adjuvant therapy, there is no need to know if there are any positive nodes in the axilla. There is no need for axillary staging, surgical axillary staging in pure DCIS. The chance of invasive cancer is very small. In elderly people, ladies with small tumors and clinically negative axillae. And coming to that, this last observation has a randomized trial many years before as a basis of this guideline, which is the CALGB guideline. Basically, they randomized elderly ladies with ER-positive cancers and HER2 negative cancers to either receive sentinel lymph nodes or not, and there was no difference, basically. Okay? After 5 or 10 years. No surgical axillary staging is necessary when ladies or even men sometimes undergoing prophylactic mastectomy for hereditary cancer syndromes. Again, all those patients should be investigated with a preoperative magnetic resonance scan of the breast, additionally to clinical examination and other investigations. There is no need for axillary staging for primary breast sarcomas and phyllodes tumors. Again, the incidence of invasive element is negligible. The second category, people that need to have sentinel lymph node biopsy, includes patients with small breast cancers, T1, and palpably node negative axilla. And again, there might be micrometastasis or other types of metastasis, but not evident on clinical examination. But there is a lot of research and many studies and meta-analysis, 6 meta-analyses in fact up to now, and they show that it is not, it is an indication for sentinel lymph node. Again, when we have a bit bigger tumors, T1, T2, so up to 5 centimeters, but palpably node negative, with abnormal axillae on imaging studies, that even have a positive lymph node needle biopsy, we should consider doing an axillary lymph node staging, a sentinel node, because half of them with a positive biopsy will only have 1 to 2 positive nodes, and this is now an option to avoid axillary lymph node dissection. In DCIS, with a palpable mass now, so if you have a DCIS on core needle biopsy, which is behaving like invasive cancer, if there is suspicion or requires a mastectomy, then those patients should be evaluated with sentinel lymph nodes. When people have small cancers with 1 to 2 positive nodes, and they have conservation therapy with whole breast radiotherapy and some type of adjuvant treatment, Again, this is quite a hot topic, and this is very well proven that if you omit axillary dissection in patients with breast cancer that either have just sentinel node micrometastasis, long follow-up, 10-year follow-up, the IBC SG23-01 trial. It is a multinational prospective trial, inferiority trial, and it showed that when there are micrometastases, you don't need to do axillary lymph node dissection. And the American College of Surgeons Oncology Group Z11, which is another trial that has now published data after 10 years of follow-up, and it included women with T1 and T2 invasive primaries that were randomized into two groups, and some only had the sentinel lymph nodes, and the other group and axillary dissection, and the other group didn't have the axillary dissection, and there was no difference again in overall survival or time to regression. And so these two trials give us the basis of avoiding axillary lymph node dissection and just doing the sentinel lymph node biopsy in that group. And even if we have 3 sentinel lymph nodes, so T1 and T2 with a clinically negative axilla, so this is defined as early breast cancer, when you have a small cancer that doesn't have a clinically evident axillary metastasis, can be treated with axillary lymph node, sentinel lymph node biopsy and radiotherapy, with the same survival and with less complications compared to axillary lymph node dissection. So 2 trials, the Amaros trial, again with a long follow-up, approaching 10 years, T1 and T2 primaries, up to 3 nodes, and randomization into the 2 groups that we just discussed about, and the same survival and significantly less morbidity in the radiotherapy group. And the Hungarian trial, again, long follow-up. They only included ladies with tumors up to 3 centimeters, so between T1 and T2. But apart from that, a very well-planned protocol and similar results. Continuing to the indications for just a sentinel lymph node biopsy, we can include all women that are clinically node negative after neoadjuvant therapy. And in these patients, we need an image-guided biopsy before neoadjuvant therapy. And we should keep in mind that the sentinel lymph node biopsy performs very well in post-neoadjuvant setting. The ultrasound examination is good. It can suggest a treatment response, but it's not reliable enough to determine the surgical approach. So a sentinel lymph node biopsy is suitable for patients who were palpably node negative, but biopsy-proven node positive before the neoadjuvant therapy, as long as they are palpably node negative after the neoadjuvant therapy. And even for people with node-positive disease, upfront patients, so clinically node-positive, the false negative rate of the sentinel lymph nodes, if you take 3 or more sentinel nodes, use a double tracer technique, and if you do a tagging of the originally biopsied pathological nodes, it has a very small false negative rate. So again, there is a trial, which is the American College of Surgeons Oncology Group Z1071 trial that included patients with N1 and N2 disease. So N1 means up to 3 involved axillary nodes, N2 means 4 to 9 involved axillary nodes, and all those ladies, they had neoadjuvant chemotherapy, and the ones that were negative, and they were tested with this dual technique and had 3 or more nodes, showed a very small percentage of false negative results on the sentinel node technique. All right, this is important. After breast conservation, when you have a recurrence but a clinically negative axilla, so if you remember the scenario that Professor Durante was talking about, the lady who had a recurrence 2 years after surgery, when you have a negative axilla, you can do the sentinel lymph node biopsy before. But of course, it is depending on the extent of surgery, especially if you had oncoplastic surgery, if you used implants, if the patient had radiotherapy, if the patient had a mastectomy. These are all factors that will diminish the sentinel lymph node accuracy and sensitivity. So keep that in mind. We can do it, and if negative, one should have doubts. If positive, this is obviously more important. Moving on to the indications for axillary dissection. If you have a clinically positive axilla, need N2 or 3, again, in these patients, you should do a guided biopsy before neoadjuvant therapy or before definitive surgical treatment to avoid dramas. If you have patients with advanced axillary disease who receive neoadjuvant therapy, and since the performance of sentinel node is uncertain because of the lymphatics draining to different groups, bypassing the involved nodes, if you like, then those patients would need to have axillary dissection. Supraclavicular nodes are regarded as metastatic disease in the latest classification, and internal mammary nodes again is a sign of systemic involvement. If you have patients that are not eligible for one of those trials that we discussed before that showed that after 2 positive nodes with some other factors can be treated conservatively, then you should do a lymph node dissection. And if the patients are clinically positive in the axilla but are ineligible for neoadjuvant treatment, then they should have an axillary lymph node dissection. Following neoadjuvant therapy, axillary lymph node dissection is indicated for patients who remain palpably node positive, and if they are clinically negative but they have a positive sentinel lymph node after neoadjuvant therapy, it's not clear in this setting whether this is just enough, or whether you should go on to axillary node dissection, or whether you should just do radiotherapy. The current recommendation is for patients to have axillary lymph node dissection, because every malignant cell is very aggressive. They survived chemotherapy and targeted therapy, so they could be giving rise to a metastatic focus. So the guidelines are for pro-axillary lymph node dissection, but there is a lot of research going on, and we're expecting the Alliance A011202 trial. Inflammatory breast cancer certainly is still an indication for axillary lymph node dissection. And if you have an invasive recurrence with a clinically positive axilla, that's an indication. If you have axillary metastasis from an occult breast primary, if you remember about the breast primaries presenting with metastasis and without a definitive primary being discovered on investigation, they used to be treated with all various treatments, such as mastectomy, double mastectomy, mastectomy and axillary dissection. It is now being replaced by systemic treatment, and if they remain node positive, they should have axillary lymph node dissection. So it's quite complicated now, and hopefully the future is going to be better. And what we are appreciating more and more with the results of the various trials is that what is important is the biology of breast cancer, and what is a linear parameter is the burden of disease in the regional basins. So the burden of disease is being seriously adopted as far as the axillary staging is concerned, and we have various stages discriminating between isolated tumor cells and microscopic or macroscopic disease, and this can be therapeutic stages and prognostic stages. I mean, TNM staging is based on prognosis, isn't it? What is happening at the moment is that we are sequencing treatments to minimize axillary lymph node dissection. So the tumor subtype is very important. We know that HER2 positive and triple negative cancers respond much better to preoperative therapy, whereas the estrogen receptor positive and the progesterone receptor positive but HER2 negative, so the luminal type of cancer does not respond all that well to neoadjuvant therapy. If people have extensive nodal disease to begin with, neoadjuvant therapy is their only chance to avoid axillary lymph node dissection. And if they're node negative, well, it depends, depends on the biology of their tumor, and perhaps it would be a good idea to go on with surgery if they have small tumors with clinically negative axillae and are HER2 positive, because there is a chance that they will only have 1 or 2 or 0 sentinel nodes. Okay, so they will not need to have the axillary clearance. And I mean, sometimes in surgery you feel a bit overtaken by the advances in the other fields, and one can ask the question, what's happening with the surgical techniques? Have they evolved as much as it is possible? There are some developments. We're trying to establish techniques of decreasing the complications from axillary lymph node dissection. There are some known risk factors such as obesity, extensive surgery, perhaps radiotherapy, and new techniques are evolving, such as axillary reverse mapping, the arm technique, and even more advanced lymphatic transfer and lymphovenous anastomosis requiring microsurgery that are being performed selectively at various centers with good results, but obviously they're variable. There is a lack of prospective data for the time being, and those techniques should be tried and entered into research. Especially axillary reverse mapping is a promising technique that basically identifies the arm lymphatics within the axilla and trying to avoid division during either sentinel lymph node biopsy or axillary lymph node dissection. And there is some prospective data that shows very small lymphedema rates and very small recurrence rates, which are good and are promising, and they led the development of some multi-institutional trials that we're awaiting their results. And technically speaking, there is an introduction of dye, either methylene blue or ICG, from the upper inner arm, and after some time you will observe the arm lymphatics and the lymph nodes, and of course they will be related to the important landmarks of the area. The axillary vein is very important, and the thoracodorsal bundle is also very important. And if you think about it, it divides the axillary region into 4 quadrants, and the surgeon can intraoperatively avoid the nodes, identify and avoid the nodes that don't need to be resected. So in a way you're doing a targeted axillary dissection when necessary, and also you're being very careful during the sentinel lymph node excision, which is it's quite promising, and it's not very difficult to do. So to conclude, the guidelines for the surgical management of the axilla in breast cancer are evolving, parallel and driven by advances in systematic therapy. In patients with early breast cancer, the overall survival and local control are not related to the extent of axillary surgery. The presence of a high burden of axillary disease is an indication for axillary lymph node dissection, and new surgical techniques aim to increase the safety and decrease the complications of axillary surgery. Thank you very much.